Medscape. This is Dr. Mark Lewis. I am a gastrointestinal oncologist. I'm recording this at the end of March 2024, and just last week I was asked to comment on whether or not a member of the royal family is suffering from a GI malignancy. I refer not actually to King Charles, but to Princess Catherine. This has been a difficult year for the royal family. We now know that at least two prominent royals are dealing with cancer. But what I wanted to address is not necessarily the intrusion into their privacy. I am not going to be speculating on what either the king or the princess have as their underlying diagnosis. I want to talk about language. So Princess Catherine in particular is under unbelievable amounts of scrutiny. I've heard it said, and believe it to be true, that she's among the most photographed people in the world. And as such, her appearance in particular is a matter of great debate. And the fact that she disappeared out of the public eye for several months led to all kinds of rumor-mongering and some really horrible and salacious speculation. And she came forward, and I admire her candor in doing this, and told us last Friday that she has been diagnosed after abdominal surgery in January of this year with a cancer. She did not specify more than that, nor do I think that she had to. I think she did it in part, again, to dispel a lot of this really horrendous gossip about her and her family. And I empathize with her that she explained that she wants to control the messaging of this diagnosis and her treatment to her children. And having gone through cancer myself and tried to explain it to my kids, that may be the one level on which I can relate to the princess. I'm certainly not in the public eye like she is. But it was interesting to see the reaction to, again, the words that she must have so carefully chosen, and even how, despite all of that careful messaging, her words were misinterpreted, especially, again, by the public. So first of all, there was the announcement by Kensington Palace back in January that her condition, and I think this was intended to reassure us at the time, was non-cancerous. And I realized that the public at large may not understand the quite possible revision, not just of the intent of a surgery, but of the diagnosis postoperatively as a pathologist examines the tissue. And again, there's any number of operations this could have been. I'm not going to guess which one. But myself, when I went through pancreatic surgery in 2017, knowing full well that I had neuroendocrine tumors in the head of my pancreas, it took weeks in multiple pathologists and different institutions before my pathology was finalized. And I think that sort of behind the scenes scrutiny of tissue is not necessarily known. That process is not necessarily known to the public. And then also I realized, and again, I know she was threading the needle between comprehensible language and precise medical terminology. I think she was misunderstood when she talked about preventative chemotherapy. And again, I see nothing mendacious in that, just like I see nothing deceitful about the revision of her diagnosis from benign to, unfortunately, malignant. I think what she was describing, actually, was adjuvant chemotherapy. And when I first heard about adjuvant chemotherapy as a fellow, I thought, how am I ever going to do this? How am I going to practice it in good conscience? And just as much, how am I going to explain it to patients? Because often, after an R0 resection, a curative intent resection with negative margins, a patient will be sent to us from a surgeon, and that surgeon may have either used the phrase or implied, quote unquote, "we got it all." And that makes the conversation with a medical oncologist then quite difficult, because if they got it all, what is the point of chemotherapy? And in fact, what is the raison d'etre of the medical oncologist? And again, to this Medscape audience, I think these principles are clear, but I realized last week that the general public does not necessarily understand why on earth we could conscionably administer chemotherapy when there's not still a solid tumor present. And again, poor Princess Catherine, I think, suffered from some of that misunderstanding. Again, people questioning the veracity of her statements or, again, her overall health. And I want to be clear. Again, I respect her privacy. In fact, she ended her very well worded and articulate statement really with a request that we honor that. But what I'm getting back to is an issue of scientific literacy that I think has become really worrisome over the last 4 years. And of course, I'm referring to the onset of the COVID pandemic and beyond. And particularly in cancer, words matter. There was also just a really well-written editorial in the New England Journal of Medicine called "What is Lymphoma?", where an oncologist, Benjamin Bippler, was explaining to his mother the findings of her colonoscopy that were then relayed to her through the patient portal. And this strikes me again as perhaps the unintended side effect of the 21st Century's Cures Act, where patients who are reading, say, a radiology report may not understand the terms tumor, mass, lesion, neoplasm. These are not perfectly synonymous. They don't all mean malignancy. And yet, that is what our patients might take away. So, for all of the understandable concern about the royal family and certainly the elevated level of celebrity that they hold in the UK and worldwide, I respect their circumspection. I respect their word choice, but I think, again, in trying to be all things to all people, I think something was lost in translation. And our job as doctors is to be clear, but also to be precise in the words that we choose. So I hope this commentary will resonate with you in that respect. And again, I wish everybody, royals or not, the best of health. Thank you.